Greetings, RRS members and visitors. Today we have the pleasure of hosting Dr. Lydia Zablocka and Dr. Michael Weil. The format for today's webinar will begin with a brief introduction from Dr. Weil, followed by a quick presentation from Dr. Zablocka, and the floor will be opened up to questions. Throughout the webinar, please pose questions in the Q&A box to the right of your screen. Dr. Weil has performed duties for RRS as a counselor at large, and we're honored to have him here with us today. Sir?
Hey, wow. It's a real pleasure to introduce Dr. Lydia Zablocka. Lydia is a professor in the Department of Epidemiology and Biostatistics at the School of Medicine at UC San Francisco. She serves there as leader of the Occupational and Environmental Epidemiology area of concentration. Those of us in radiation research know Lydia mainly for her extensive work in many publications in radiation epidemiology, biostatistics, and risk modeling. Her particular area of interest is in occupational radiation exposures and health risks to nuclear power industry workers and workers in uranium fuel production cycle. She has served for many years as a principal investigator on NCI-funded research on Chernobyl, and she's published a number of very important papers in that area on exposures to ingested and inhaled radioactive iodines during childhood, and how that leads to increased risk for thyroid cancers that are similar to those from external beam radiation. Now, what most of us didn't know is that she also conducts clinical epidemiological investigations, including research into the long-term health outcomes in children conceived after infertility treatment. And since the start of the coronavirus epidemic, she's been working with various groups within the Bay Area on providing information about the epidemic, and has a website where she answers questions about coronavirus. And so it's a pleasure to introduce her for this webinar. The webinar is Ask an Expert, a Q&A session with an epidemiologist to discuss the most burning questions about coronavirus epidemic. Lydia?
Thank you very much, Mike, for the introduction. I'm very happy to be here to answer your questions. Even though I'm not an infectious disease specialist, I teach epidemiology to medical students and residents and fellows at UCSF, so I have a very keen interest in infectious disease epidemiology. One tidbit, perhaps you don't know, my mother was an infectious disease epidemiologist, so I used to go with her on outbreak investigations. So you could say that I've been doing it for a very, very long time. I just wanted to give you a quick update. So this is a slide from Johns Hopkins University website where they're collating all the cases in the world. So this is accurate as of 10:30 a.m. Pacific time. And we now have 2.25 million confirmed cases. The number of total cases is probably much, much larger, but these are the ones that are confirmed by PCR tests. Almost 150,000 people have died around the world. We have more than 3 million tests in the US, and we have 30,000+ of deaths. You see the distribution of cases here on the world map, and it's pretty much what you've seen on the news. One sort of perhaps not widely addressed question is that the outbreaks a lot in Central and Latin America, and in Africa you don't hear too much about it, but there is a lot of infection spread going on there. This map also is accurate as of yesterday. It shows a distribution of cases in the US by county, and the darker colors or purple colors indicate the largest number of cases, confirmed cases. And of course, the largest number of cases is in New York, in Long Island, and there are some very dark areas indicating a lot of transmission going on in the South, Louisiana and New Orleans. One of the things that today, perhaps you could ask me some questions, but I wanted to sort of preemptively talk a little bit about this is what strategies work both on the population level and at the individual level. And so you hear a lot about sheltering in place. What I want to show you are the actual data showing how the sheltering in place works. New York City and Los Angeles have different characteristics. So New York City has much higher density. However, these are big metropolis, and the cases were introduced approximately at the same time. So the cases we see on the left in Los Angeles, where the first deaths and the first cases occurred at the beginning of March. And then on the right, you see New York City approximately the same time. And then there was a much more exponential increase in cases in New York than it is in California. Could this be all attributed to shelter in place? I would say, and the scientists are saying, that a lot of it could be attributed to it. But of course, as I mentioned, density and some other things, public events, could be attributed to this, to widely different scenarios in Los Angeles and New York City. And then comparing Los Angeles and San Francisco, again, San Francisco Bay Area was the first area in the country to introduce the sheltering in place on March 17th. But what's unsaid is that big employers in the city, Facebook, Google, and others, which have which have tens of thousands of people working, they allowed telecommuting beginning on March 2nd and 3rd. So that was already sort of some kind of shelter in place. And if you look at it, the distribution of cases is really affected by the shelter in place and the early introduction. So it's not just sheltering in place, but it's a timely introduction of this measure. You've heard a lot on the news about various models. The first models were proposed by the Imperial College in London. There are also modeling that is being done out of University of Washington. And at the beginning, you might have heard the numbers that the projected number of cases in the US was 264,000 deaths and millions of cases. The take point out of this is that you probably know it in your own research when you're working in radiation labs, biology, microbiology, population studies, is that the model is as good as what you put into it, garbage in, garbage out. And so at the beginning, we didn't have very good data. We had the data projections from other countries, China, Korea, Italy. Now we are using our own projections and our own modeling based on these local data, and these are much more accurate numbers. And so this curve, the big purple one you see in the middle, this was based on early projections out of other countries. As we know more, as we are improving our models, these projections are getting better and better. So for example, for California, the number of deaths for the 6th county in the Bay Area was projected to be 45,000 deaths. We've currently only seen 170. So what does that mean? That means that this model projects that we are staying and sheltering in place and using all other measures for quite some time. This is the slide from actually 2 weeks ago when Dr. Fauci was saying, what do we need to be able to do to prepare to stave the possible resurgence of COVID-19? And he said 3 simple things. We need tests, isolate cases, and do contact tracing. This is very simple epidemiological method. We know about contact tracing, isolation, and testing for more than 100 years. This has been applied in various epidemics, thinking about plague, cholera, and others. And so these are successful methods. Unfortunately, it starts with number one, you have to be able to test. Even though we have done 3 million tests or more in the US to date, this is not nearly enough. We are at probably 10–15% capacity of testing from what we actually need to do to be able to open it. So what do we need to do to go to the life we want to, life we aspire to? We need to have low transmission numbers. And here is a description of what we need to get these low numbers. We need to have this testing, as Dr. Fauci said. We need very vigorous methodology for contact tracing. This is not anything new. As I said, it's known for 100 years, and other countries in this epidemic have been able to implement it. So of course, when you have hundreds of thousands of cases, you cannot do tracing. But if you have a small outbreak, this is the time to start with the contact tracing. Contact tracing, once we identify someone is tested positive, we need to implement supervised isolation. Means if the symptoms are mild, the person has to stay at home. If they are moderate or advanced, they probably need to be hospitalized. All those in their family who live with them, who live around them, who they could have contacted, those should be traced and contacted and quarantined. We also need, in order to be able to return to the life as we aspire to, we should be able to have adequate hospitals, ICU, and ventilator capacity. And as we found out, we are lacking in some areas more than in others on these three indicators. And finally, we need to have, we should be able to really, when you drive a car, just slightly tap on the gas. So we should know when we could return. If we have the controls, if we allow people to return to work, how could we recall them if there is a new outbreak? So we should have a lot of options to close the schools or open the schools quickly. There are some predictions from the scientists that in order to achieve herd immunity, and herd immunity is a term we use in epidemiology where we say so many people are infected or have had the disease that there's no longer transmission of infection in the community. It depends on the virus. For this particular virus, we think because it's so contagious, we probably need 70% of people to have had the disease or be immune to it in order to have this herd immunity. 70% is a very high number. Right now, we estimate that approximately 1% or less of the US population has been affected. This includes people who are also not tested, but we are projecting that they had a mild case of the disease and they are immune right now. And so to build, how do we build from 1% to 70%? Vaccine, of course, is the best, but we are at least 12 months away from vaccine and possibly more because there are initial indicators that the virus is mutating, which makes development of the vaccine much harder. So we need to ensure that we could care for all the sick within the hospitals. We should prevent infection in people who are at high risk for severe disease. That means that sheltering in place probably will remain in effect for some categories of the populations who are vulnerable. We need to build our capacity to protect the health and well-being of the public. So we should have adequate supplies of PPE for healthcare professionals and adequate supplies of protective measures for the general public. And we should reduce social, emotional, and economic disruptions. This is an example of how the contact tracing could work. This is an example from the San Francisco Department of Public Health. So cases identified, contacted, demographics, screening. We right now have implemented this in San Francisco, where every new case is traced, isolated, and the contacts quarantined. Just a quick sort of explanation. Isolation and quarantine are not synonymous. Those are two different terms. Isolation is for the cases that have a confirmed disease. So coronavirus is an infectious agent. COVID-19 is the name of the disease that people develop if they become symptomatic, but some people do not develop COVID-19. They are asymptomatic. If they have the COVID-19, they should be isolated, and those who are in contact with them should be quarantined. So isolation is recommended for 72 days and perhaps additional time until the symptoms such as fever and coughing subside. And quarantine usually should be about 14 days. And the last slide that I wanted to show, why is this case investigation and contact tracing essential? This is essential. We can't go back to work without knowing that. We cannot open the economy without knowing it. Contact tracing, this shows that one person could infect many different ones. This particular virus, we are learning more and more every day about it, and the news, unfortunately, are not very good. For example, the news yesterday was that in the young population of our Navy sailors that were on the cruise ship Roosevelt, 4,000 people were tested, 4,000 plus, 600 of them turned positive. And out of those positive, almost more than 60% did not have any symptoms. So among this younger age, the percentage of asymptomatic was more than 60%. We have previously thought that perhaps it's around 20% or maybe 40, maybe as high as 50, but we have to now adjust our numbers. So it's more than 60% that are asymptomatic, at least in this age group of young, healthy people. So I would stop here and take questions if there are any questions.
Yes, ma'am, there are a few questions. I'm going to pull them up right here so that you can see them. 1 second here. And here we go, ma'am.
Do you want me to read them?
Yes, ma'am.
To my understanding, the recovered patient should have anti-COVID-19 antibodies in their plasma. Why is it taking so long to use their plasma to treat patient? Is it more complicated? It is a little bit more complicated. Thank you for this question. The reason for that is that people develop antibodies in different ways. There are also different antibodies. And so some people do not have enough antibodies in their plasma that could be used. Plasma also needs to be processed. In the best case scenario, if we have someone donating the plasma, it being screened, separated, it takes at least up to around 2 days to give it to the patient in need. But if you know someone who is recovered, who has recovered from COVID-19, the best place to volunteer and donate plasma is Red Cross. So if you go to the website of the Red Cross, there is a place where you could answer a questionnaire if you recovered from COVID-19, and they will direct you to a local place where you live, where you could donate your convalescent plasma. Next question. Are there COVID-19 antibody tests that provide results for both the early and late responding antibodies? That is a very good question. Thank you. So right now, FDA is not regulating the antibody test. There's at least about 100 different companies who are working on that, companies and academic centers that are developing their antibody test. And they are testing very different antibodies, but more importantly, their accuracy or specificity is very different. For example, yesterday I saw an announcement flashing on the screen that a company in Richmond, California is providing tests that cost $125, and in very small print it said that the specificity is 89%. This is very low. For a blood test, we are always aiming to at least have 95%. That means there is a lot of false results. I am not aware of a test that has been sort of universally accepted as the best serology test. But I'm hoping that in the coming week, we will have we will coalesce around a couple good tests which will be prevailing. But right now, there is a lot of scams on the internet with tests that are not good. And essentially, even if you take them, you will have false assurance about having protected or not protected. Do you theorize the weather will have an effect on COVID-19 transmission, or whether this virus might have seasonal behavior? Again, a very astute question. Actually, scientists are divided about that. Right now, there is epidemic going on in the southern hemisphere. There is a spread and transmission in Australia, in Latin America, in Southeast Asia, where the temperatures are quite high for the time of season. What I've heard said is that there might be a slowdown, but not a complete stop. And so there might be some seasonal behavior, but not as much as we're expecting. There wouldn't be a complete stop of transmission because of increased temperatures. There might be a slowdown, but even that is not guaranteed. This virus has very high contagiousness. What is the current estimate of the mortality rate of those infected, and what factors may influence this? Thank you very much. This is a question that's on everybody's mind, and mortality, of course, depends on the age structure of the population. In countries like Italy, where the proportion of those aged 70 and above is much higher than in other countries, their mortality was close to 10%. So this would be cases that have died in hospitals. But there are also a number of cases in Italy where people died at home. So as time goes by, these will be counted, but right now they are not. In the US, mortality ranges from anywhere from 2 to 4%. So in New York City, it's been estimated to be about 4%. And that's primarily because of the high percentage of people aged 50 and above. There are definitely factors that are influencing mortality. There is a company that provides software support to many hospitals in the US. The name is Scripps, and they published a report last weekend where they looked at the anonymized data from electronic medical records in the United States. And this company is providing this support for all the states and many big hospital systems. And so what they were able to do is to look which comorbidity at entrance to the hospital was connected with mortality. And strangely enough, the number one comorbidity correlated with mortality was kidney disease. The next one was hypertension, and then diabetes. So these are the factors. And then after that, number four was chronic obstructive pulmonary disease and other diseases, respiratory diseases. So kidney, hypertension, diabetes, and COPD and other respiratory diseases. So people, for example, information on diabetes. For two people of the same age, if someone has type 2 diabetes, they have a 3.2 times higher risk of death compared to someone of the same age and other characteristics, but without diabetes. So these are quite high and measurable risks.
So those two questions above, I don't think we've got those ones yet. So I've heard estimates of the sensitivity of the viral tests around 60%, which is not great and suggests we could be missing a lot of cases. Is this true? And how does this affect modeling and prediction?
So the PCR test, as you all well know, PCR test looks for tiny genetic material from the virus, amplifies it, and then detects it. Again, there are different tests. The one that I'm aware of have much higher sensitivity. I don't think it's 60%. I think it's much higher than that. I think perhaps you're talking about sensitivity of the test for detecting antibodies. So far, many are very low. But the one to detect the infection, the PCR test, the majority of them have much higher sensitivity, and they might miss some percentage of cases, but nowhere near 40%. The second question, is the SARS genome still pure, or has it mutated in all the different continents? There was a recently very good study published in the Proceedings of the National Academy of Sciences, which looked at the samples from around the world to detect mutation of coronavirus. The study collected the samples up until March 4th, so it's a little bit old in these terms, it's 1 month old. But up until March 4th, they were able to identify 3 strains of virus. And so type A is the original one, and it's connected to the virus that has been seen in the bat family. Then there is a type B, which has 2 mutations compared to type A. And then there is a type C, which has 1 more additional mutation compared to type B. So the number of these mutations are not large. We do not know how these 3 different strains, if they are related to the severity of the disease or not. But here is the distribution. Type A, even though it's the original strain, is primarily distributed on the west coast of the US and somewhat in China. But the predominant type in China is type B, and it's also the predominant type in Europe. And then type C is predominant in Singapore and other southeastern countries, and is also sometimes some cases in Europe. Why that happened, we don't know. If this distribution has changed since March 4th is also unknown, but of course scientists are tracking it very carefully. And of course everyone wants to know, does this mean we need to have different types of the vaccines? Does it mean that some of the cases are milder because they had a different strain? So that question is unanswered as of now. Why are individuals with diabetes more likely to show severe effects? Thank you. Some suggestions are, so people with diabetes have, this is a pronouncement, diabetes is just one of the signs of the problems with metabolism. And so we believe that on the cellular level, there are some problems with cell defense, and perhaps that has something to do with the virus entering through the cells in the alveoli of the lungs. I'm sure the research into this ongoing, but nothing has been published to really prove. The only thing that we suspect is that this metabolic syndrome, that the metabolic problems that patients with diabetes are experiencing is just probably is the main problem. Can you please comment on projections for COVID-19 reemergence in the fall? I've seen a number of different projections, and as I've shown on that map, comparing different projections. And I think the reemergence will depend on the measures that will be in place over the summer. So we see, the picture that I showed, we see very clearly the measures show themselves in 2 weeks. So we need to be very careful and so we cannot just open the country and go back to how we lived before. That has been discussed by many experts. It's not possible. It's not going to happen that way. We will have to sort of modify our expectations to adjust to a new normal. And the new normal would be that we will have to have staggered return to work, probably in shifts. The same is true, staggered return to school, where children are split into shifts in school, morning, afternoon, maybe Saturday was even proposed. So there will be a lot of adjustments that we need to do to prevent the reemergence of the epidemic. I think the national discussion about when to return is showing two very important points. You cannot have a blanket open or close measure, and it's really up to the local health, Department of Health, who have their finger on the pulse. They know the cases, they know what's happening in their hospitals, they know what's happening with their test. They are in the best position to say what is the situation in that community and what preventive measures could be done. But again, we cannot return to work until we have testing and contact tracing and isolation or quarantine of those with a disease or infection. I read that there were 3 variants. Yes, so I think I answered that question. The data is a little bit old, so we are hoping that there will be an update on this. But again, New York City and East Coast has primarily type A, and West Coast has primarily type B strain. Evidence exists for potential reinfection. Is there also significant evidence that convalescent patients have robust immunity against reinfection? What is the currently observed relative proportion of these two groups? So the study, in order to assess reinfection, we have to have the benefit of time passed by. And so there is almost no evidence of reinfection that has been published so far in the US. So we are relying on this information on studies that have been done in China and South Korea. And South Korea had this big outbreak in one city, and that outbreak has gone down, and they were able to identify that 3 weeks after the people tested negative, they again were testing positive. So the number of people that have been reported was, I believe, less than 190 cases that had reinfection. And the question is this because they had persistent infection from the beginning, or is this truly a new infection? A lot of scientists I've heard discuss it, and infectious disease epidemiologists in my department were a little bit skeptical about this reinfection. They were thinking that perhaps the testing for recovery might have something to do with it. So currently, the protocol in South Korea is that if someone tested positive, they stay in quarantine or isolation, depending on their symptoms. And then in order, if they want to end it, they have to be tested. They have to have 1 negative test. So at the end of 7 to 8 days, they take a test. And if it's negative, they need to retake the test within 24 hours. And if they have 2 negative tests within 24 hours, they're considered recovered. Infectious disease epidemiologists in the US actually disagreed with that. So our approach is to test within 48 hours. And so we think that testing this close 24 hours to each other, perhaps it misses some, perhaps this infection raises and wanes. And so perhaps we need to have a longer period of time between 2 negative tests to truly certify that someone was infectious or not infectious. And so in Korea, after someone tested 2 times negative, and then they haven't tested positive within 3 weeks, that's considered a reinfection. But it quite possibly could be still the same original infection. What do we know about robust immunity? This is the $64,000 question. What we know so far is that the amount of antibodies is different in people. We don't know how long the immunity lasts, but we do know that different people have different amount of antibodies. And that's why not everyone who is recovered is a suitable plasma donor, because they don't have enough antibodies. I don't have the numbers about relative proportions of these two groups. I think that the chance of getting reinfected, based on what we know about other coronaviruses, of what we know about SARS and MERS epidemic in the past from that family of coronaviruses, it is unlikely, but perhaps possible to get reinfected, but it is unlikely. Does the US death rate data include deaths in care homes for the elderly? Here in the UK, deaths in care homes are not yet included. We only report the numbers of hospital deaths. And so the fear is that we are underreporting the actual number of deaths. Thank you very much for that question. That is true. So it depends on the state. So in some states, the people who died at home or care facilities are counted, and in some states are not. And so right now, we don't have a very accurate estimate. We probably are underestimating at least 10 to 15% of deaths. That's the number I have seen. I've heard about the cytokine storms that contribute to the severity of sickness. Is this type of response something that contributes to severity of many other infectious diseases? That is correct. So cytokine storm is in sort of lay terms is the overreaction of the body to the infection, where our own immune system goes into overdrive and is really overwhelming the whole body. Cytokine storm is known in other diseases, and it frequently happens to oncology patients who are being treated with very strong drugs for cancer. So chemotherapy for cancer could cause the cytokine storms. So our physicians are, at least oncologists, therapeutical oncologists are familiar with that. It is less well known in the emergency department. So this is something that physicians are now trying to teach each other and help each other, because we do have some ways of dealing with cytokine storms. And it's possible that this new drug that has shown promising effect, remdesivir, again, it's coming from it's previously approved drug, but not for this. So there are a number of drugs that we know that could help with the cytokine storm. What we need to do is probably improve our protocols of treatment for COVID-19, because right now, as of now, different hospitals have different protocols. We do not have a national protocol for treatment of COVID-19. And the reason for that is that we initially saw that there's not much that could be done. So the only therapy for these patients was supportive therapy. But now it emerges that we know how to deal with cytokine storm. We know that some drugs are helping. So we do need to work on developing on a national protocol for treatment of disease of this COVID-19. Do vaccinations against tuberculosis in children help in resistance against COVID-19 infection? I have not seen the evidence. I've heard that there are some suggestions that tuberculosis vaccinations could help. I've heard that measles vaccinations could help, but of course, a high proportion of the US is vaccinated against measles, so that doesn't seem to be the case. But I haven't seen any hard numbers or scientific studies. It seems that the coronavirus cases in equatorial countries is still low but increasing. Can that observation give hints on the seasonality of the virus? Absolutely, absolutely. So we see big outbreaks in some places. So we've seen outbreaks in Central Africa. Unfortunately, we do not know much about those because the data is not being collected. WHO doesn't have access in some cases to these places with outbreaks. We've seen actually a lot of violence happening in some countries against public health, international public health experts. So we know that outbreaks are going. We don't know the mortality, we don't know the spread, and we cannot so far get any useful information because of that. But the mere fact that there are such outbreaks is pointing to the direction that it's unlikely that seasonality will have a big effect on the spread of the epidemic in the US. Eye doctors are warning people to cover their eyes to avoid catching COVID-19. Please comment. So the reason for that is that the epithelial cells of the eye, of the inside of the nose, lungs. These are particularly susceptible to the virus. This is where it has a special sort of hooks where it could enter the cell. And that's why you see physicians having these shields in front of their face to protect their eyes, or special goggles to protect their eyes. This is a point of entry for the little droplets in the air. Is there any evidence for transmission of RNA viruses from human to animal and back to human? I am not aware about such transmission, but you have probably heard on the news that large cats, animals could be infected, and they could exhibit even some symptoms of some respiratory symptoms of the COVID-19. How that happened, of course, there must have been a human to animal transmission, but I don't think there was any information that there was another transmission from the animal to the human. I haven't seen any data published on that. Is a cytokine storm related to toxic shock syndrome? I think it's slightly different, but perhaps an expert could talk about that. I know it's cytokine storm is an overreaction to the body, while toxic shock syndrome is overwhelmed response to the large amount of infection and in the bloodstream. If you measure the death rate by number of deaths to number of result cases, the number are much higher. Why is this not the method used to discuss deaths? This is primarily because in epidemiology, we use the ratios where the numerator always has to be included in the denominator. So we calculate risks or rates. So risk would be the number of people who died over the total number of people who were infected. And if we want to call it a rate, we also need to include an element of time in it. So number of people divided by the number of people who died divided by the number of people who were infected over a period of 1 month will give us a monthly rate, death rate. I think that dividing, so what you're describing is death rate to those who resolved. This is kind of odds. So this is very similar to odds of betting, one side to the other side. What people are primarily interested, what is my personal risk? So when a patient comes to us and asks, what is my personal risk? In order to answer that question, we will tell them in epidemiological studies, when a large group of people who are similar to you, this is what was the proportion of them who developed the disease, died, or something happened to them. And so this proportion of people similar to a patient, this is called the risk. And this is the sort of the explanation why we always define it that way.
So that essentially concludes all the questions that we had for today. If there was any other topics that you wanted to touch on before closing out?
I don't know if it's possible for us to open for discussion.
For discussion as in open communication?
Yes.
No, that's not possible to do in this format. But we actually do have 2 more questions that I'll read out to you.
Okay.
So can you please comment on the issue of genetic susceptibility?
So far, I haven't seen very good studies that talk about coronavirus susceptibility. We do have quite a bit of information knowing who is at increased risks due to some diseases, and we discussed those today. But I haven't seen any information on genetic predisposition. And you will remember that, comparing this coronavirus epidemic to the HIV epidemic, information that some people could be genetically protected from HIV infection came much later in the HIV epidemic. It wasn't known in 1983, it became known much later. So we need time and information and studies to identify this information. We don't have that right now.
And last question being, can one sign up to get vaccinated without being exposed to COVID-19?
Yes, so the vaccination volunteers in the vaccination studies that are ongoing, and there are quite a few ongoing in this country and around the world, they are volunteers who are free of the disease. So they have not been exposed and they have never had COVID-19. That's one of the requirements to be eligible to participate in vaccine studies. My understanding is that in this country, the most advanced is the clinical trial ongoing at the NIH, but it's still in phase 1, which means they're only testing the toleration of the vaccine. So we are not even far removed to see of the effectiveness of the vaccine, which will come in phase 3.
So yes, that concludes the Q&A session for today. I just want to go ahead and thank yourself, Dr. Zablocka, for being here, as well as Dr. Weil. And some other things that we'd like to push out would be that make sure that you guys are signing up for the next webinar, which is Dr. Kowalczyk for Sex and Gender Science on Tuesday, April 21st. And last but not least, we want to thank all of our attendees for coming, as well as tuning in, and all these amazing questions that we've had. Any additional questions, would you be available to potentially answer them post-webinar?
Yes, absolutely. So you could either email me directly, or you could post a question on the blog that I have. I think it was posted in the original announcement about this webinar.
Yes, and we will be sending out the link for that coronavirus Q&A blog for Dr. Zablocka. So without any further ado, we're going to go ahead and conclude the session, and you'll be able to rewatch this not only on RRS's YouTube channel, but also in the email we send out. So thanks again.
Thank you for your questions. Stay well.
Yes, ma'am. Bye.